So good evening, everybody. My name's Dr. Dennis Goodman, and it's great to have you all come out. It feels like yesterday that we did the microbiome. It seems like we're meeting once a week. But I am a clinical professor here, and I'm very involved in the prevention program here, and I'm the director of integrated medicine. And this program and Health Heart series is very near and dear to my heart. We've been doing this for a few months. And I just want to remind you that the next one is Tuesday, March 27th. We're going to be talking about the truth about tobacco, and I'm very interested in educating people about nicotine supplements. Are they safe? There's vaping, and this is a big thing out there now, and the kids seem to think that it's somewhat safer than cigarettes. You're going to find out all about it and what are the problems and how many people actually are still smoking. So this is information for those of you who don't know, but this is how you can find out more about our series, what's coming up, and anything else that you want to know about the program. Now, Anya here, I always give her a shout out. Without her and Julia, we would have no program and do an enormous amount of work and make this happen for me. So thank you, Anya. I really appreciate it. So I've also told you that if you've got any suggestions for programs, we're getting to the point, and I'm just putting these up. I'm not going to read them all. But these are all topics that we've already actually addressed, all in the realms of prevention. And we're probably going to have to start cycling some of these again. And in fact, I think this is our first big cycle, Women and Heart Disease, that does come up every year. And that's our program for tonight. I want to just say how really honored I am that we have three superstars here tonight. I don't know if any of you were at their last lecture, but it was one of the highlights of our lecture series. And every February, we have Women and Heart Disease Month. And clearly, there's some men in the audience. Either they want to know about heart disease or they care about their women. But I'm glad to see that there's so many of you here. I can't tell you how many people came up to me just before this program, women, and said, you know what, I had a toothache and I had a back pain. And my doctor didn't realize I was having a heart attack. And I'm sure you're going to be hearing a little bit about that tonight. I'm going to throw out one thing to these ladies. Why do women have different symptoms? I don't really get it. And maybe that's going to be one of your toughest things to answer. But we definitely know they present differently, and you're going to hear all about it tonight. I decided also to do something different. And I think it's because Dr. Gianos gave me this advice last time. These ladies' bios are more like a book. So what I decided to do is just give you really 2 sentences about each one of them. The bios will be out there. You can read about them. They are all superstars at NYU. And I'm the first person who's going to speak is Dr. Nieca Goldberg. She's the medical director of the Joan H. Tisch Center for Women's Health at NYU. She's a clinical associate professor at NYU School of Medicine. And she's the co-medical director of the 92nd Street WISE Cardiac Rehab Program. She's written books. She's on TV. She's a real spokesman for women and heart disease. And the second person who's going to speak is Dr. Harmony Reynolds, and she's an associate professor of medicine at NYU School of Medicine. She's the co-director of the Soda Center for Women's Cardiovascular Research, and she's the associate director of cardiovascular clinical research, very involved in a lot of excellent, outstanding clinical research here at NYU, and she'll be telling you something about that. And then the third person to speak is Dr. Gianos, and she's a colleague of mine in the preventative medicine program. She's an associate professor of medicine here. She's the co-clinical director of the NYU Center for Prevention of Cardiovascular Disease, and she's directed the Preventative Cardiology Fellowship here for 8 years. She's a strong believer in prevention and, of course, women and heart disease. And really what we're about is prevention. So when we have a topic like women and heart disease, our real focus is how do you prevent it? And if it does happen, how do you prevent it from happening again? So ladies, I'm very grateful. I'm wearing my red sweater that I bring out once a year, but everybody tells me it looks good. I may have to start wearing it. So, so Nieca, thank you so much, Dr. Goldberg. She's going to kick off, and when the three ladies have spoken, we'll take some questions at the end.
Well, welcome, and I want to have the opportunity to say I hope you're having a very healthy and happy Heart Month. And it's not only Women's Heart Month, Dennis, it's everyone's Heart Month. So it's great to have some men in the audience, too. So my task today is to discuss the symptoms of heart attack in women and what puts you at risk. So I'm going to put it in perspective. Since the 1980s, the American Heart Association and the Center for Disease Control has been studying statistics on death rates due to cardiovascular disease. And something very interesting has happened. Right around 2011, we found that women's heart disease risk cardiovascular disease risk has been starting to go down, which is very promising, considering that about 5 or 6 years before that, major awareness programs were started by the American Heart Association, such as the Go Red for Women campaign, and the National Heart, Lung, and Blood Institute started the Heart Truth campaign. Now, when we talk about cardiovascular disease, we're talking about the heart and the blood vessels. And we're going to spend a lot of time today talking about how to reduce risk for heart attack and the vascular disease process that causes heart attacks. And about 2/3 of the women in our country who die suddenly of heart attacks have at least one risk factor that we can prevent. And that means high blood pressure, high cholesterol, quitting smoking. And sometimes those women die of those heart attacks with no warning signs at all, but the question remains, maybe they didn't realize they were having warning signs. So really big thing is to understand that if you're having symptoms, what do you do next? And when you break down why people die of cardiovascular diseases, the majority of them are due to coronary heart disease, the blue part of the pie, which is heart attack. And then about 17% of those are due to stroke. 18% are due to other forms of heart diseases, and those are arrhythmias, valvular heart disease, and conditions such as that. And heart failure and blood pressure are about 9%. And what's interesting, these may be due to the death rates, but when people come into the cardiologist, many times we're treating them either for coronary heart disease or talking to them about how to prevent it. So let's talk about how to recognize symptoms that you might maybe at risk for having a heart attack or actually having a heart attack. And I'm showing you the picture that I saw when I was a second-year medical student. And this is a middle-aged businessman clutching his chest. And he didn't really have to say everything. And he doesn't really have to say anything. Everyone in the room recognizes this man may be having a heart attack. And he has tightness in the chest, and it could be radiating down the arm or up the neck, and he looks in distress. And oftentimes the symptoms are provoked by physical exercise, like walking up that flight of stairs, the small flight of stairs on a cold winter's night, or emotional stress. Now, what's very interesting is when I went to school, I thought it was really interesting going to medical school because I had just graduated from Barnard College, which is a women's college, and then I went into medical school, and I thought it was like the biggest fraternity in my class. Now we can say that medical school classes are more than 50% women, and we're glad that we have both men and women training to and practicing medicine. But what's very interesting is very early in my career, I met a woman who had been to a number of doctors, been told that she was stressed out, needed a vacation, and one doctor even gave her a prescription for Valium because she had tightness in her chest and she was feeling really tired. And he just said, "You're stressed out." And one day I met her when she was in the coronary care unit, and it ended up that she didn't have a heart attack, but I did a stress test on her where she walked on a treadmill, and I had to stop her in less than a minute of exercise because she had those symptoms, and she was short of breath. And then I had to tell the doctor who was caring for her that the test was abnormal and she needed further testing. And he said, Nisa, that's ridiculous. She can't have coronary artery disease, clogged arteries, because she's a woman. Well, he'll never make that mistake again. But she ended up having a coronary angiogram and had a 99% blockage in the artery supplying the front part of her heart muscle. And so sometimes a person doesn't have the typical symptoms that you're looking for of heart disease. They're not textbook. And many women that I see in my practice don't have textbook symptoms. Although tightness in the chest, it feels like an elephant is sitting on your chest or somebody is squeezing you a rope across your chest. Sometimes you can have shortness of breath without any chest discomfort. So, and as Dennis mentioned earlier, pain in the upper back, shoulders, neck discomfort, feeling as though you're just going to collapse, generalized weakness, maybe associated with nausea, dizziness, fainting, a rapid heartbeat that makes you feel as though you're going to faint. And if it's in the lower part of your chest, don't grab the Maalox because it could be your heart. Now let's talk about these symptoms a little bit more, because I want to make everyone in the room understand, yes, there are other conditions that can give these symptoms where you can experience one or more of these symptoms. But if you have risk factors and this suddenly wakes you up from your sleep or comes when you're sitting down, it's not time to look up on the internet, am I having symptoms of a heart attack? The time comes when you have to call 911. Another mistake that a number of my patients have made is taking an aspirin and just waiting for something to happen. And aspirin is only one of the many things that we do to stop a heart attack in its track. It's not enough. So if you plan to take an aspirin because you think you're having a heart attack, then you need to be calling 911 simultaneously, because hospitals are equipped to do rapid blood testing to diagnose whether or not you have a heart attack. They also do an electrocardiogram and may be giving you other medicines. And I know Dr. Reynolds will be discussing some of the tests that we actually use to diagnose whether a person is at risk for or having a heart attack. Want to also talk about sometimes you get these symptoms and they're less intense than the day you have a heart attack. And I'll give you an example of a woman I took care of many years ago. She actually was walking up a hill because she worked at the New York Botanic Gardens in the Bronx, which can be very hilly, and realized she had to stop because she got this uncomfortable back pressure. Well, one day it didn't go away, and she was taken to a local hospital emergency room and was told that she was having a heart attack. So it's important to take these symptoms seriously, and if they come on a time when you're exercising, you stop and it goes away, that's the time not to restart exercising, but to call your doctor. So we also know that heart attacks are more common in people who have risk factors, and that's family history, especially if you've had a parent that's less than 50 when they have their first symptoms of heart disease. As we get older, our risk increases. Cigarette smoking increases risk in women threefold, as well as bringing on menopause 3 years earlier. And ladies, smoking also causes wrinkles. So whatever you do to quit, you could help a lot of things. Diabetes, a very strong risk factor for vascular problems. High blood pressure. Many of you have read in news, and maybe your doctors have told you that the blood pressure guidelines have changed, and that high blood pressure is now defined as 130/80. Obesity, or being overweight, but particularly carrying the weight in the middle. Being inactive. So it's as simple as taking a walk can reduce your risk, and Dr. Gianos will go over that in more detail. Something called the metabolic syndrome, where you have 5 of these risk factors together, like elevated glucose, high blood pressure, weight, belly fat, and high triglycerides. A few tests have come up in the news. One is a test like the high sensitivity C-reactive protein that measures inflammation, and it's best used to assess risk in people, men who are over 50 and women who are over 60. Lipoprotein A has had a resurgence in the last few weeks. It's a molecule that's like a lipid, only they find that it sticks like glue to the wall of the artery and increases risk for coronary heart disease. However, some people recommend taking medicines to lower lipoprotein A, but we yet don't have research to support that it helps. But particularly in women, markers of heart disease can occur young, like when you're pregnant and have preeclampsia, a condition of high blood pressure and edema and protein in the urine during pregnancy, high blood pressure of pregnancy, gestational diabetes, and autoimmune disease, which is more common in women than in men, can also increase risk for cardiovascular disease. And who else needs to be concerned about their heart? If you've received radiation therapy and certain chemotherapies for breast cancer or lymphoma and other cancers, talk to your doctor about checking out your heart. So in answer to Dr. Goodman's question is, why are women's symptoms different? Well, it sounds like a good question from a man. Does it have to be the same? But I think there's one thought about this, and it's a question of whether or not the symptoms are really different or women are communicating them differently. And the studies to date that have actually looked at that have not been able to give us good information about why the symptoms are different. I think for all of us in the room, we should know all of the symptoms so we can get the help that we need quickly. And I wanted to point out, this is a photo from the doctors that I work with at the Women's Center, that it takes many different doctors of many different specialties who take care of women to sort of assess risk. And one of the highlights of my day as a cardiologist is when our dermatologist thought her patient had symptoms of heart disease, and I evaluated her, and we found out that she needed a coronary stent. So I think as we raise awareness, because just about 6 months ago, there was a study that showed that only 42% of cardiologists felt comfortable assessing women for cardiovascular disease. I don't think that that's a problem here at NYU. So I want to thank you very much, and I want to wish you all a happy Valentine's Day.
That was fantastic. I don't know if I can follow that so easily. But I'm Harmony Reynolds, and I'm here to talk to you a little bit about diagnostic testing. And I am a fast-talking New Yorker, so you can holler to slow me down, or we can save any questions for the end in the panel. So I'm going to talk about choosing cardiac testing for women. And I think that when we're contemplating any medical testing, it's really important to keep in mind what our goals are. And sometimes it's obvious, but it may need a rethink. So when we're talking about cardiac testing, the two major goals are, let's find out if these symptoms are coming from the heart, and let's understand and reduce our risk of heart attack and death from heart disease. There are two types of patients. Now, for most of this, I'm going to be focusing on the stable patient, the people like us who are walking around and who aren't in the middle of having a heart attack. But I think it pays to know the enemy and know what we're trying to prevent. So I'm just going to say a few words about our unstable patients who are having heart attack. What is a heart attack? Well, it's damage to heart muscle, and it's usually caused by cholesterol plaque that's in the heart arteries. How does this cholesterol plaque build up? Well, we start out with normal arteries. The normal artery here has an inside lining that's kind of like a skin inside the artery. It has a muscle layer and it has an outer layer that's holding it all together. But as we get older, some cholesterol and inflammation will accumulate and will start growing into the wall of the artery, making the whole artery get bigger. And in the initial stages, there's still plenty of room for the blood to flow. But if this process keeps on going, the artery may become blocked by plaque. These small plaques in the middle here are common and they're potentially dangerous. Our eyes tend to focus on these that look the worst, but I would argue that these are the ones we need to focus on the most. These start to show up even in the late teens and 20s. Everybody in the room probably has several. But not all the small plaques are dangerous. Some of them are. We call them vulnerable, but we don't know at this point exactly what makes a plaque vulnerable. We have some clues, but we don't fully understand it, and that's a big area of research, including here at NYU. Now, ultimately, this is an artery shown in a different view, and ultimately this plaque can lead to heart attack. Here we see a bunch of plaque in the artery. We see that it's expanding the artery outward, and if at some point that plaque decides to break, then a blood clot can form. It can completely close that artery, and then we can have a heart attack, all the symptoms that you heard about from Dr. Goldberg. A heart attack can be deadly, but it's also preventable, and that's why we're here, and it's treatable. Research at the Soter Center for Women's Cardiovascular Research investigates the best testing for women with heart attack, but I'm not going to focus on that today because we're here talking about prevention. So now let's go to our stable patients. Maybe they're having symptoms. If we know those symptoms are coming from the heart, we call them angina or angina, or maybe they have no symptoms. So if we have symptoms, this is a very common situation that we encounter all the time. A woman comes in, or a man for that matter, with some symptoms, and they want to know, is this coming from my heart or not? So our testing choices for that are actually, there are a number of them. We have stress tests, we have CAT scans, and we have an invasive angiogram or a cardiac cath. Now, for most stable patients, the cardiac cath is not going to be the first test. For most patients, it's going to be a stress test. But even a stress test comes in all different flavors, so let me give you a quick primer. We can stress the heart in order to see how it responds to stress by having people exercise or giving them medications that might speed up the heart or change the way the blood is flowing to the heart. And EKG is always recorded, and that helps us to determine how the heart's responding to that stress. But we often also use imaging tests in order to learn how well the heart is squeezing, for example, or where the blood is flowing when we put these patients under stress. So how do we decide between an imaging sort of souped up stress test or a plain vanilla stress test? The imaging stress tests are a little more accurate, and they give a little better risk prediction, especially if they're positive. But there's a balance, there's a trade-off for that. The imaging tests are more expensive. Most of them involve some radiation exposure. And in truth, most of the stress tests we do are negative, they're normal. So we don't really need that better risk prediction for everybody. And even the more accurate stress test isn't perfect. For years, when we did stress testing research, we would get results that would show how accurate the test was. And that was considered the best way to evaluate the test. But the field has moved forward. And now we need to answer the question, well, if I get this test, how's it going to change my life? Is it going to make me live longer? Is it going to make me not have a heart attack? So now we're starting to get research studies that are addressing this question. And one of them that I think is really relevant here is called the Women Study. In this research question, we came with, if in women who can exercise, what kind of stress test is better to prevent death, heart attack, and heart failure? And this was led out of the Emory School of Medicine. Patients were randomized to a plain stress test or a nuclear stress test, which is one of those imaging stress tests. And it turned out there was no difference in the likelihood of heart attack or death or heart failure. So the plain stress test actually did really well. It was less expensive, and it didn't include any radiation. So the American Heart Association now recommends that for most people with a normal EKG who can exercise, an exercise stress test is good enough. But if you need imaging, especially for younger women, it's recommended to use a stress echocardiogram. This is an ultrasound test for imaging of the heart, and it doesn't involve any radiation. Or you might use a stress MRI, which again doesn't involve any radiation. Nuclear stress testing is wonderful, but there is that trade-off. So let's say you had a stress test. Now you have the results. Now what? What if it was positive? If that stress test was positive, there's probably plaque blocking a heart artery, like in this diagram here. And the symptoms that you went for the stress test to find out about, they were probably coming from the heart. This is what it looks like when people have a stress test. I'm sorry I didn't have a woman, but you can see the leads are on the chest, so it's very hard to find a diagram with a disrobed woman. So there are these EKG leads on the chest, and there's a blood pressure cuff. We're monitoring the EKG. There is always a nurse standing right by and a doctor on site. So when the stress test is positive, people then say, well, wait a second, how much blockage do I have? Is it 50%, 60%, 90%? I want to know. Well, it's like this cat. Give it to me straight. It's curiosity, isn't it? I'm going to die. But the studies surprisingly show that in many cases, the percentage of the artery that it's blocked, whether it's 70 or 80 or 90, may not matter. Might not matter if it's 50, because there may be more to risk prediction. So again, the ultimate goal is I want all my patients to be like Betty White. She's 1,000 years old, she's working, she's active, she obviously feels great. I want all my patients to live long and feel well, and I want it for myself. So when it comes to, now we've had a positive stress test, and we need to treat this stable patient. We've made the diagnosis. There's artery blockage. We definitely want to use medicines, because medicines have been proven to save lives. And there are a number of different medicines that have been proven to save lives. We need to use them all. But should we use a stent? Should we try to prop open that bad blockage with a little piece of metal mesh? And you can see one here. Well, maybe yes, maybe no. This is a study funded by the government called Courage. And it was called Courage because at the time, for a doctor to consider treating her patient by just giving her medicines and not opening a blocked artery with a stent was considered extremely brave. But it turned out that it was just as good to treat with medicines alone as to use medicines and use a stent up front. Some of the patients got stents later, but they weren't any more likely to die or have a heart attack with either approach. And you don't need to be a scientist to see these two lines overlap perfectly. These two groups did exactly the same. So now stents started to come into question, not for heart attack patients. For heart attack, they're critical, but for stable patients who've, let's say, flunked a stress test. Here's another study in patients with diabetes. They were randomly assigned to best medicines alone or best medicines with stents or surgery for bypass. The survival is just the same. Now we have the question, well, what if these patients didn't just kind of not do great on their stress test? What if they really flunked? Maybe stents and surgery are going to work better for those patients. We're investigating this now. This one is led at NYU. It's called the Ischemia Trial, and it was a large grant from the government, trying to find out if an angiogram is needed after a moderately or severely abnormal stress test. We've randomized 5,179 patients, and we'll have an answer in a few years. So if the stress test was positive, medicines, absolutely. Stents, maybe. What if we get the answer we were looking for? The stress test was negative. Negative's good in medicine. Well, probably there wasn't any plaque that was badly blocking the artery, and probably the symptoms weren't related to heart artery blockage. But is that enough? Well, no. A normal stress test is not a clean bill of cardiovascular health. And this is always a worry for me when I send patients for stress testing, because I'm a little afraid that they're going to come away if they get a good result and think everything is fine and go and celebrate with a cheeseburger. That doesn't work. So stress testing is very good, but it's not perfect. So that's why I've put here why stress testing fails for screening, and I should say it can fail. Because a coronary artery must be narrowed more than 70 to 80% to cause symptoms or a positive stress test. But a plaque of any size can rupture and cause blood clotting, leading to heart attack. And because of that, a stress test may be normal, even just hours before a heart attack. Because if the plaque wasn't blocking the artery at that moment when the stress test was done, stress test will look good, and there can be loads of plaque, but it's not blocking the artery badly, like that diagram I showed you. And then when that plaque decides to break, everything changes. So again, which kind of plaque is more important? Well, these severely narrowed plaques tend to be kind of stable. The irony is they look terrible on an angiogram, they look terrible in this schematic, but most of these tend to be fairly quiet. They make people uncomfortable when they walk, but they may not actually cause heart attack. Most heart attacks start with mild plaques, but there's no reason for an angioplasty or stent then, and these are not identified with a stress test. So we have to really change the way we view sick arteries. For years, everybody thought the sick artery is the rusty pipe, and it makes sense. The artery is blocked, I've got this stuff in there, get it out, and I'll feel better. But that's not the whole story. The plaques we worry about the most are more like a raw egg. They have a lot of gooey stuff inside, this cholesterol and inflammation, and they have a thin shell, which is called the fibrous cap, and if it breaks, the stuff oozes out, and it's a big mess. In the case of the artery, the plaque shifts, the flowing blood is exposed to the inside of the plaque, the blood can clot, and that causes a heart attack or a stroke. So how does medication and lifestyle change work? How does all of our prevention work? Well, it changes the plaque on a microscopic level. And the analogy I use with my patients is it's a lot like hard-boiling an egg. The egg is the same size, but it is totally different inside, and it's much less fragile. In this case, I don't know if these show up as looking the same size. They should. But here, when we treat with medicine, diet, with exercise, we get less of this greasy cholesterol, less inflammatory cells, and a thicker, safer cap. So that's what we're aiming for. So if it's all about the plaque and not necessarily how much blockage there is, maybe we should just be looking for plaque. We have that as an option for diagnostic testing. In fact, we have several different flavors. So here on the left is called an electron beam CT or a calcium score. It shows us these white splotches, which is where the artery has been hardened by plaque and calcium. And then on the right, we have a much more sophisticated test, a CAT scan angiogram, which can show us great detail about the artery and where every little blockage may lie. Each one has its advantages and disadvantages. The calcium score involves less radiation, it's cheaper, but it only finds hardened plaque. So it's not going to tell us if chest pain is coming from the heart because it's not going to give us any idea of how blocked the artery is. So it is used for risk assessment, and that's very valuable. The CT angiogram has radiation that's usually lower at NYU than a nuclear stress test, and it can find every kind of plaque. And it's better if you need to know the percent of the artery that's blocked. So slightly different uses for these two tests. Again, I told you that now we're holding our diagnostic tests to the highest standard. How does it change people's lives? So here's a study randomizing people with symptoms to a CAT scan as their first test or a stress test as their first test. And it turned out they both did very well. There was no difference in the outcomes. It was a low-risk population. So in general, we think that either test might be a good way to start. So now I've given you all this information about tests, and you might say, okay, well, which one do I have? It's a trade-off. CAT scans show us plaque, and that is very useful, but they don't always tell us for sure if the symptoms are coming from the heart, because lots of us have plaque, and we may not have symptoms. A stress test will give us a much better sense of whether those symptoms were coming from the heart, because we may exercise on the treadmill and get the same pain, let's say. But most people with a normal stress test still have plaque, so we still need to be very attentive to risk reduction. My recommendations are, if you have symptoms, a stress test will help to tell if they are from heart disease, and that is usually my first test for patients with symptoms, including women. CAT scans are especially useful when it's unclear whether cholesterol lowering is needed. I think you'll hear from Dr. Gianos about the decision-making process a little bit that doctors use to decide if cholesterol lowering is needed. When we're on the fence, we'll often pull out CAT scans. Plaque is treatable and heart attack is preventable, so do everything you can for prevention, and I'll turn it over to Dr. Gianos so she can tell you how. Thank you very much.
Yes, she does always speak fast, but I think that message must have come across clearly because I thought it was awesome. So yes, what I'm going to do is now transition to essentially how we can avoid this whole thing entirely. Why have coronary artery disease, right? So let's just prevent it. And basically what I'm going to talk about is the fact that cardiovascular prevention for women really needs to happen across their entire lifespan, not just when they've already developed the disease late stage. So a couple of things I'm going to go over are the importance of cardiovascular prevention for women, doing it at all ages, assessing risk specific to each individual person, because the risk is very different, and treatment will therefore be very different depending on the person. There are specific risk factors for heart disease that we'll review, and we need to target those risk factors. If you can improve your risk factors for heart disease and get them all to goal, it's highly unlikely that you will then have develop heart disease or have any cardiovascular events. And lifestyle is a very big component of this. So cardiovascular disease, unlike some other diseases, one is it's an ideal disease for prevention, partly because it's very common. It's the most common disease for both men and women to die from. it is something that we can modify by behavior. About 80% of cardiovascular disease can be modified just by lifestyle. It takes a very long time to develop. However, once you do end up having symptoms, you can very quickly progress to having disability, to being very, very limited by your disease, whether it's heart attack, stroke, heart failure. And currently, unfortunately, there is not a cure, but we can undoubtedly prevent secondary effects of heart disease. So Dr. Reynolds really went through this very well. I think the whole concept of this plaque, which now we realize, over many years of research, that this is something that accumulates over time. And even these smaller plaques are very risky for a patient and are more likely to be the ones to lead to a heart attack. The other thing is that this is something that is not just relevant to the heart. It is the entire cardiovascular system. It's the same process that's happening in the arteries that go to the brain, to the legs, to the heart as well. But fortunately, all the things that we do to prevent it work throughout the body. So again, of note, this is something that needs to start early. And there are differences, unfortunately, in healthcare. And over the years, we've made a lot of changes. Even to date, young girls often are not as active as boys, setting them back in terms of getting that physical activity for prevention. Heart disease prevention, especially years ago, even when I was in training, I remember even here at NYU when we'd have conference about 10 years ago, the discussion was, well, no, she doesn't need to be treated. We'll wait until menopause, then we'll start. And this has really shifted as we understand the disease process much better now. Women who are at high risk, so if you have a very high genetic risk, if you're born with extremely elevated lipid levels, other things that put you at risk, even throughout your childbearing years, from essentially menarche until your high 40s, I would say nowadays with technology. Basically, you really need to be treated during that period of time. You need to keep those levels low. Granted, during conception and actually bearing a child, we will keep women off of medications that may be detrimental, but we cannot do that for a 30-year span. So who should be treated is the question, because everyone, will have the question, well, should I be on a statin? And do I need a stress test? Do I need an advanced lipid test? So clearly there's two concepts, primary prevention and secondary prevention. So if you've already have disease, that's called secondary prevention. If you have blockages in the arteries to the legs, the heart, the carotid arteries, if you've had a stroke or a heart attack, you need to be on an aspirin or some form of platelet blocking agent that prevents clotting, and you need to be on a cholesterol medicine called a statin unless you have any issues with that. That's pretty much clear. Now, these medicines really do reduce your risk of having a second event, a heart attack or a stroke, and they're imperative to your treatment. Now, when it comes to primary prevention, in terms of predicting who might be at risk for a heart attack or a stroke, this is a lot more confusing, truthfully. And it is very different for each individual. We can't just say, well, everybody should do, one thing. Well, the one thing that everybody can do, undoubtedly, is lifestyle change, healthy diet, exercise, etc. Risk factors for heart disease, there are some that, unfortunately, we are not able to change. Our age, and this actually should say sex as opposed to gender, heredity, your genes, whatever your folks gave you is basically what you're born with, etc. Now, there are obviously many modifiable risk factors. The most common ones that are associated with heart disease are smoking, diabetes, high cholesterol, and high blood pressure. But obviously all the other lifestyle ones are extremely important as well. And in women, although we like to keep up with men in all areas, This is not one that we were looking to keep up with them. And in terms of rates of obesity, unfortunately, we're right up there, in all across the years. We have similar rates of obesity. We have similar rates of diabetes. And some of these risk factors put women at even greater risk than men individually. Now, in terms of deciding who should be on cholesterol-lowering agents like statins, and should everybody really be on them is the question. We have a number of risk predictors, different algorithms that we can plug our patients into, and it can give us a score that will help us to predict whether or not patients should be on these medications. And some of them, actually, this is one that has started to be used a little bit more frequently. The good thing about this is in taking into account race, it helps us to better predict stroke risk in women. So, for example, if you put your patient's numbers in here, a woman who's 55 years of age, who's African American, and these would be her numbers for cholesterol and blood pressure, we see that this risk predictor, just by adding the race, shows that for an African American woman, her risk with the same exact numbers as we put in for a Caucasian woman is approximately double. And that usually is for stroke prediction. Every population genetically or possibly even because of environment seem to be at risk for different things. And in African American women, hypertension is quite prevalent. And stroke is the biggest thing that we're trying to prevent. Of course, we're trying to prevent heart disease as well. And for example, in a Caucasian man, heart disease may be slightly higher of a risk. But again, the treatment we use is going to prevent all forms of these disease. But this just helps us figure out who should be on these treatments in a better way. So for specific risk factors in women, having a low HDL or a low good cholesterol actually puts you at quite high risk. And that's actually even more predictive than having a high LDL or bad cholesterol. And lipoprotein A that Dr. Goldberg did describe earlier is actually a great risk predictor that we're starting to use more and more. It is more of a genetically determined cholesterol molecule that essentially puts you at risk both for plaque and also for clotting. And essentially in people where we're not able to account for risk and we think there might be something else genetically driving heart disease, for example, in the family, this is something that we are seeing quite often to be elevated. And it could be more predictive, especially in younger women. And triglycerides, although we don't necessarily target triglycerides in all cases, we may not start medicines specifically to treat the triglycerides, we know that they're predictive, and then we just get their LDL, their bad cholesterol, to an even lower number. You saw a little bit about the tests that we use for cardiovascular disease, and this is actually a carotid artery, where basically what you see here is plaque that is present in the carotid artery, very similar to what we saw earlier in the coronary artery. And this is the same calcium score test that Dr. Reynolds showed that shows that there is calcium here in these arteries, and calcium essentially tends to form around where there is that soft cholesterol plaque and is predictive. So these tests are for people who don't have disease yet, and we're trying to decide, for example, whether to put them on medication. What do? Our targets, our risk factor targets are pretty much the same for men and women. There's not been any differentiators here in research to date as to how to treat each of them. And your bad cholesterol ideally should be under 100. If you're at higher risk, it should be under 70, and many feel nowadays, because of a lot of trials, that it should be even lower than that. Your good cholesterol for men, greater than 40 is what's suggested. For women, greater than 50. And that goes up generally with exercise. And triglycerides should be under 150 for normal values. Now, with respect to blood pressure, in terms of who should be treated, for the most part in the population at large, under 140, if they're greater than 140/90, they would be automatically put on medications with the new guidelines, 130/80, if they have heart disease. But normal blood pressure, 130/80 is undoubtedly a high blood pressure based on the current new guidelines. HbA1c is a marker of your sugar. It's one number that just tells you how well your sugars have been controlled for the prior 3 months. And if you don't have diabetes, that number should be less than 5.7. If you have diabetes, it should be less than 7. And your BMI, your body mass index, should be less than 25. So these are some numbers that you can say, okay, am I optimized? Are all my numbers in the correct category? Are they already at goal so that I can reduce my heart disease risk? And multiple cholesterol trials over the years, and even more recently, have shown that the lower your LDL, the better you do in the long term. Fortunately, there's many ways to lower that LDL through medication, but also multiple ways through lifestyle. And definitely one of my approaches, and the one that I advocate for the most, is lifestyle change. And obviously, if you do make these change, you may have certain side effects, including weight loss, low cholesterol, low blood pressure, increased confidence, look better, have more energy, etc. So again, and this is not easy. Obviously, weight loss is challenging, and it's something that, doesn't come automatically, but it is something that you can achieve. You just need people to guide you, you need a game plan, and you need to give yourself some slack, because it's not going to be easy, and you can get there. In terms of diets, and I'm just going to touch very briefly on diet, because this is a whole other lecture that I'm sure our dietitian will again do. She did it last year, but she's great. There's so much out there that's confusing, as this cartoon, I really think it explains it really well. Our menu is divided into 3 sections: cancer-causing foods, artery-clogging foods, and foods that are being boycotted for political or environmental reasons. Very confusing there. So there's trials in diet. One that's very well known is the Predimed trial, where they looked in people who didn't have heart disease yet but had risk factors for heart disease, how they did on a Mediterranean diet. And in this trial, they basically showed that with the Mediterranean diet, they were able to reduce heart disease by approximately 30%. And this is predominantly because of reduction in stroke, which I would argue is a good thing. It certainly reduced heart attacks as well, but the most benefit was seen in stroke. So some dietary tips, and you'll probably get these slides later, are replacing good fats with bad. Replacing good fats for bad. And essentially the monounsaturated fats and the polyunsaturated fats are the types that are important to have in our diets. Omega-3 fatty acids are very important for reducing cardiovascular disease if you get them in food. And essentially they can help the blood vessel walls, they can block platelets. There's a number of beneficial effects from those. Having a high fiber diet will lower your cholesterol. It will keep you more full. There's a number of benefits from having fiber, and specifically soluble fiber is most likely to lower your bad cholesterol. Foods that are rich in antioxidants are very important, and having a diet that's varied, that has all different types of foods that have various nutrients, is also important. For hypertension, specifically lowering the amount of sodium in your diet is key. Avoiding foods specifically that might have a lot of sodium, for example, sauces, frozen dinners, soups, deli meats, even turkey that you might think is healthy through deli meats. It's processed, usually has tons of sodium, not so ideal. And reducing alcohol consumption and not smoking. So again, even just overall weight loss overall, if you are overweight, can help to improve all of these risk factors. Some important things to achieve that: you obviously need to have less calories than what you are expending. And to do that, though, you need to have the right balance so that you're not hungry all the time. Having whole foods instead of juices, for example, is definitely of benefit. Avoiding extra calories that you might have in soda. And exercise, obviously, is a very important part of maintaining weight loss. For more information about this, our dietitian here, Elisa Ganguza, is excellent. She's very involved in research studies that we're doing here, and she's very knowledgeable. You can meet with her, obviously, or you will probably have another talk eventually from her here in the setting. Sure. No problem. You can get her number. And I think, honestly, for a well visit, it's helpful for everyone to meet with a dietitian just to learn where they can optimize and easy ways to do things. And then smoking cessation is key. Smoking is unacceptable. The wrinkles are terrible, I agree. But the health effects, in every single aspect, there is a new study that looked at all other studies, and people say, well, I only have one here and there. Even one cigarette has almost as high a risk of smoking, regularly and smoking high amounts in terms of causing heart attack and stroke. So keep that in mind. And there's resources out there to help you to quit. Using apps, just tracking your activity can help you get really motivated to do this. If you can get to the gym, if you can get to some kind of formalized program, great. If not, just track your steps on the days that you're busy, take the stairs, whatever you can do. And again, you can get your steps in whatever form you want. It could be from walking. Apparently malls are open before the stores open, I heard, just for people to go walking. This is something I learned. A lot of malls, you can go in there just to get exercise. You can go to Home Depot and walk around. You can go to the supermarket. You can dance in your apartment, whatever you want to do. Just got to get these steps. So again, for women, I think that we've now recognized over many, many years that this is something that is much better served by preventing it from an early age than treating it later on. Fortunately, we're in an age where we can do both, and you can do well in the long term no matter what. But certainly it'd be prudent to do the former. And we have risk algorithms. If you're not sure if you should be on drugs, you see a specialist. They'll help you. They'll guide you. Anyone with heart disease in their family should have their family members screened to prevent heart disease. And again, there's different counseling that we'll provide during childbearing years and menopause, et cetera, but something that we need to keep throughout the lifetime. And that's it. And thank you all for coming. This is a great turnout. Thank you.